My name is Della Rocca and I work as a cardiac electrophysiologist at the University Hospital of Brussels, Belgium. The benefit of concomitant ablation with PFA and appendage closure are multiple. First of all, we are in an era of PFA and we are learning day by day that the efficiency of the procedure has improved. So procedures are shorter, is more efficient, but also in the long term we have better outcomes. We see by improving our workflow in the last years that patients have better arrhythmia control. At the same time, we want to keep the patients as much as possible out of anticoagulation. And so giving the patient the option to have appendage closure gives him also the possibility to have a life risk-free in terms of minor bleedings and major bleedings, clinically relevant bleedings. So in terms of impact of workflow and efficiency of concomitant procedures, we have the possibility to have two procedures that are very effective and with procedural durations that are contained and with a very low risk for the patient, the peri-procedural risk for the patients. So when we try to get rid of the arrhythmias of the patient, having the possibility to do it concomitantly, also in terms of control of stroke and control of risk of bleeding, increases immediately, has an immediate impact on the life of the patients since the beginning of the procedure. In terms of a lab efficiency, this is something that doesn't have a significant impact on the lab because now with the PFA we have the possibility to do procedures in a very limited time compared to standard thermal ablation techniques. And so with this time that we save with a procedure that is at least equally efficient as previous procedures, we can invest this time to have concomitant procedures and also have an impact on the risk of bleeding and stroke. Patient selection is an important part of the process to identify patients for concomitant. In my opinion, patients with a moderate risk of stroke and bleeding are the optimal candidate for the procedure, and those are the patients where we are a little bit more skeptical in interrupting anticoagulation, although some evidence suggests that we can do it, but still there is a residual risk in these patients. So if the patient doesn't have a good compliance with anticoagulation, or if the patient stops anticoagulation and has hard time keeping track of the arrhythmia recurrences because maybe it's totally asymptomatic, or because even if it's symptomatic has problems with reaching out healthcare support, then those are the patients that might benefit the most from a concomitant procedure, because in this case we take care of the arrhythmias. Those are also patients who have a moderate to high risk of arrhythmia recurrence, and with PFA we have a good control of this arrhythmic profile, but at the same time those are patients who have a moderate risk of a stroke and also a moderate risk of bleeding, and so we can take care of that and we can really have an impact on the quality of life of the patient. There are some possible limitations associated with PFA ablation, post-pulse field ablation in patients with devices. We know that certain designs are associated with a possible overlap in areas where we need to ablate. And so knowing these those devices can potentially limit the delivery of PFA in certain areas. And that's why it's important to have a strategy when we think if and when to ablate and if and when we think to occlude the appendage. But we know from the literature there are certain cases where pulmonary veins could not be fully isolated because of the interference existing between PFA delivery and possible electromagnetic interference with occlusion devices. So it's important to be aware of these possible limitations and organize our strategy accordingly.